All right, everyone. Well, welcome back for our second plenary address, and I'm really delighted to introduce Dr. Kate Mulligan. Dr. Kate Mulligan leads high-impact policy development, advocacy, and research on the role of community-scale leadership and intervention in the production of health and well-being. She's an assistant professor in social and behavioral health sciences at the Dalla School of Public Health at the University of Toronto, and the senior director of the Canadian Institute for Social Prescribing with the Canadian Red Cross. Kate, over to you. We're delighted to have you join us today.
Thank you, Michael, and thanks, everyone. I am really thrilled to be here with you today. I'm just waiting for the capacity to share my screen so I can get my slides up and share them with you. Here we go. Okay, can you see my slides okay? I hope you can. I'm going to get started as though you can. Thanks again for being here and for sharing your expertise. I've had the opportunity to listen into several of the workshops and presentations today, and I think a lot of what I'm going to be saying this afternoon will support what you've been hearing all throughout the day about advancing health equity by putting the data into motion, putting it into action, and doing that by building community so that we can do this all together in an equitable and safe way. So I'm speaking to you today from a Dish with One Spoon Wampum Belt territory, and I know we have had wonderful opening land acknowledgement and welcoming ceremony by Elder Wendy Phillips, so I won't repeat things, but I will encourage you to check out talkingtreaties.ca to learn more about your relationships with Indigenous people and with the land as a treaty person. The Dish with One Spoon Wampum Belt reminds us all to care for one another and to care for the earth that we live on, the land that we live on. So please do take the time on this beautiful day to be outside, to reconnect your feet to the ground, and to recommit to your work as a treaty person. I'm going to talk about just 4 principles this afternoon about building a community that helps us move forward together. And the first one is that community supports health. Community is good for us. Community is part of health systems, but it's not always recognized as such. So here are the World Health Organization's building blocks for health systems. They include things like service delivery, health workforce, health information, and so on. But you may notice there are some important things missing. And one of the most significant things that's missing is any reference to the social determinants of health. Not only our healthcare access and quality, but also the neighborhoods we live in, our social and community context, access to education, economic stability, and so on and so on. By now, we are well aware of the impact of social determinants of health on our health and well-being. We know that upwards of 50% of our health outcomes are determined by factors outside of our healthcare and our biology, right? Things that are happening in our lives. And this graphic comes from 2013, so 10 years ago now. But have we really put this into action in a significant or systematic way? Well, we haven't, and here's the proof. The proof is, where do we put our money? Where are we investing? What matters to us? What is important to us? Don't worry about every single piece of spaghetti in the spaghetti graph. I think the most important thing to note is that the vast majority of the $94 billion that Ontario spends on health goes toward hospitals, physician services, and prescription drugs. That is the same set of priorities that we have had for well over 100 years. Even though we now know better, we know that we need to be putting money into things like community care, public health, Indigenous health, and so on. We've got a lot of work to do if we're going to be putting our money where our mouths are. And here's just one example. This year, the Canadian Centre for Caregiving Excellence put out a report that noted that if all caregivers decided to take a week off, we would experience the collapse of our health and care systems before noon on the very first day. And that's just caregivers alone. Caregivers contribute more to Canada's GDP than agriculture, fishing, and forestry combined. And that means they make up the largest part of Canada's healthcare system. But we don't see that reflected in our priorities and in our spending. So here's what it would look like if we went back to those World Health Organization building blocks and really included community. So we see those traditional building blocks in the orange color. And in the blue, Emma Sachs and colleagues have added in here the household production of health, where lots of that caregiving happens. And remember that that is racialized, feminized care, both in terms of the paid labor of personal support workers and others, and the unpaid labor of household caregivers. It includes the social determinants of health. It includes the work of community organizations, societal partnerships, community-based healthcare workers, and health promoters. And I think importantly, for all of you on the line today who work with data, it includes really, really building in community into our information, learning, and accountability structures. So one example from my own work in social prescribing is the way in which we're trying to get a handle on just how important community services are for our health and well-being. So social prescribing involves referring a client or a participant from healthcare to community and social services. And importantly, building evaluation in from the get-go, data tracking in a learning health systems approach that allows us to really finally measure in a direct way at the individual and community scales, what are the impacts of those community supports and services, all the way from income support and housing through to community groups and gardening, physical activity, being in nature, the whole range of non-clinical supports that help address those social determinants of health. What is the impact of those on our individual and collective health? Through the data tracking and social prescribing, we'll start to be able to paint a picture. And that picture will also tell us a little bit more about what the landscape of social care really looks like in Canada and how we support the healthcare system in the way that it's traditionally conceptualized. So we can start to see that community is not just a series of disconnected neighborhood level interactions, but a whole sector of support and service that has been invisibilized and ignored. So community supports health, okay? That's the first principle. And what can you do right now to act on this principle in your life? Well, you can make an effort to make that community sector role visible in the work you do. So ask questions about what's happening behind the scenes. What data do we have or not have about community supports in health? Think outside those ministerial boxes. So in that spaghetti diagram where we saw the different places that healthcare money goes to, we want to think about community in an even broader way. So community work that may be supported by other ministries, other levels of government. Lots and lots of social determinants work happens at the municipal level, for example. We need to broaden our idea of what community health is and means as a sector. Respect those contributions that community organizations are making. You heard that loud and clear in the panel before this session. Build relationships. I often hear from people, how do I know who community is? And I think that that's a sign of just how disconnected we are in our professional lives from our own personal lives as members of communities. So build relationships with community members, and importantly, build relationships with community organizations. They're the ones who have the trusted relationships and the history of working well with their community members, and they're going to help you find the answer to that. But as we have seen, they're not particularly well resourced. Things are unstable and poorly resourced, even though the capacity, the know-how is very much there. So the other thing you can do is transfer resources and share the resources that you have with community. We need to move the needle on where the spending goes in order to really make a difference and make an impact. So where you can, pay community members to be there, share your work with community support. Okay. The second principle, community has a health history. So those of you who are clinicians will know that when you encounter a patient, you want to take their health history. You want to know about what's been going on in their lives. What are the different things and encounters with health that they've had over the course of their lives, for example. So when somebody comes in who's facing poor mental health, for example, you can start to get a sense of those social determinants of health. So on this beautiful tree diagram by Nanki Rai, you can see in green, the branches of the tree are those social determinants of health: access to healthcare, education, housing, and so on. But really significantly, those branches come from somewhere. Just like the health outcomes themselves and health experiences themselves come from somewhere, those social determinants come from somewhere. They have histories. They're rooted in things like capitalism, ableism, colonialism, heteropatriarchy, racism, and so on and so on. These are the roots of the social determinants. So when you hear people talking about political determinants or commercial ones or structural determinants, that's what they're talking about. They're talking about where access to health and the distribution of health determinants has come from. Here's another way of looking at it that comes from the Pan American Health Organization. And they put those conditions of daily life, the social determinants of health, in the center as really important precursors to health equity and a dignified life. But we need to look at that through an intersectional lens, and we need to look at structural drivers. And this is the first global framework that I've encountered that really locates history and legacy, ongoing colonialism, and structural racism as structural drivers of those social determinants of health. So we need to remember that. We need to know that the structures that we all live and work under are determined by decisions that people have made over time before us. And that we can mitigate this, we can start taking action through community governance with a human rights perspective. So here are just two examples of how this manifests in our lives. Clearly, we have had tremendous leadership by Indigenous health leaders. Many of you are on the call today, and we are so grateful to you for your leadership in really illustrating how colonialism has manifested and continues to manifest in Indigenous health. Importantly, it also manifests in everyone's health. So the healthcare systems that we have now here in Ontario were determined in large part at the time of the British North America Act in 1867. That was when the idea that health happens in hospitals by doctors and so on really took root. And we still are seeing the way that that plays out today. It's also rooted in other historical moments. So the Saskatchewan doctor strike around Medicare in the 1960s is what gave us the legacy of fee-for-service medicine. The idea that we're going to pay for private entrepreneurial physicians piece by piece, operation by operation, service by service, rather than taking a more holistic, team-based, and comprehensive approach to understanding how we fund and pay for health. So this is something that we continue to live with. And these structures don't come from nowhere, and we need to know about our histories in order to really do that. So community has a health history. The challenges that equity-deserving communities face are not inherent to those communities themselves, and they don't come from nowhere. They come from historical decisions that have privileged some people and some ways of knowing and being over others. So here's what you can do today about that. You can always take a community health history, just like you might have taken an individual health history. Interrogate those inherited health governance structures. Where did they come from? Who did they serve then? Who did they serve now? Ask about where the inequities that you're seeing come from and who benefits. Look for that historical data and knowledge. Sometimes it's hard to come by. We need to start collecting and using the data in safe ways now, so that in the future, people will be able to look back to this time as a time when we opened up more ways of thinking, knowing, and doing around health. And then consider what would be in our shared health record. If we were able to start now creating that shared health record to have a more fulsome and comprehensive health history, what should we include? Okay, the third of four, community improves quality. You're just going to get better results when you include a more comprehensive approach to working with and by and for community. And so, what happens if you don't is you end up with things like invisible women, a world designed for men, right? We know how much healthcare evidence-based decisions are made on evidence that was created on the basis of, white male bodies that were considered to be somehow the human average, where women people of color, BIPOC folks, and so on were not included and are not included often in medical research. And that's just one example. Another one on the positive side is the leadership of people who use drugs, who have really shown us that there are huge limitations to what can be accomplished without them. They're the experts in their own lives, in their own experiences, in their own care. And I can think of, even the simplest of examples at a supervised consumption site that I visited, where they initially painted the chill out room, the recovery room for after drug use, a pale yellow, and only found out later from the experts, the people who use drugs, that that color was considered totally inappropriate, unsafe, and triggering for people who had had experiences of institutions like hospitals and prisons. So they had to repaint that. And it's just one small example of the ways in which working with community can help us prevent harm and further damage. So there's some wonderful work happening in global health research around this. And I just wanted to share just a couple of examples from this paper, Bakuni and Abimbola, around the credibility deficit that happens when you don't include community well. So these are some of the things that can happen. Local experts and marginalized groups can be excluded from the scientific components of research. So, maybe you're including people as advisors or reaching out in some way, but you need to really think about sharing that full power and sharing the full authorship and ownership that fully reflects their intellectual contributions. You need to rethink the gaze of the research, aligning the research not just to the dominant audience, such that only the universal is deemed desirable, and local experts or marginalized groups or equity-deserving communities aren't even given the space to interpret their own reality. And I think this is a really important one for people who work with data, who want to be seen to have a certain amount of credibility with external audiences, decision makers, for example, other scientists. Remember that there are other ways of knowing and doing that belong to the people whose data you're using. And we cannot appropriately align research only to the dominant audience. It won't be successful. We will have a huge deficit in the credibility of that work. And I think, I'm a health interventions researcher, so I'm very concerned when we see the sidelining of local interpretive tools and data analyses, or deciding whether an intervention is appropriate, so that falsehoods are perpetuated and wrong interventions are promoted. In other words, if we're not looking at how the community themselves really interprets the data and the reality, we're going to end up with interventions that don't work well, right? That are painted yellow. And we need to do better in order that we have credible and sustainable and useful interventions. So we want to move away from that expert model at the top of this diagram, down toward doing things with and by the people who are affected. So we don't want everything done to us or at us. We don't want things to be done for us. We've heard some tremendous leadership on nothing about us without us, from disability communities, from Black communities, Indigenous communities, people who use drugs, and so on. And we can move even further. We can do done by us, for us, where the role of experts who work with data and others who can support participation in the system is to walk alongside and provide enough support such that the community can take leadership in researching, evaluating, understanding, and sharing data about its own experience and what matters to them. The idea is that we're shifting the focus away from what matters, what's the matter with us, toward what matters to us. Away from what's wrong with us and toward what's strong with us. So here's an example from my own experience. I just came off a term on the Toronto Board of Health, where we were able to make a number of important decisions that really had an impact during the COVID-19 crisis. And part of that is because this board has public members, so regular community folks like me who aren't, city councillors on the board to help make decisions that matter to the community. So it was because the board asked for it that we started to see the collection of socio-demographic and race-based data. that we saw the release of data around workplace outbreaks, that we saw action on ventilation to the extent that the city can take action there, that we saw a commitment to a whole of government health equity strategy and working with community ambassadors who have the expertise to work directly with communities. And also importantly, that we saw a renewed commitment to a more equitable board composition. So when I left the board, we made sure that the incoming board was more representative of the city itself. So those are some of the things we can do when we have community governance, when we have regular folks from community around the table to help make decisions. And then we have sort of an alternate example in Hamilton, where the Board of Health just is made up of the existing City Council. And there has been a long, long effort to try to include more people from the community with lived experience. And that, I think, could have made a big difference in the kinds of decisions that were made in Hamilton over the course of the COVID pandemic. So community governance really looks like that number 4 in the middle. When we have engaged citizens, we try to get things done and make a difference in the world, and we measure the results. Aligning all 3 of those is what we're trying to do when we're doing effective community governance. We know there are lots of great community organizations that are really good in that green number 1 spot, engaging citizens and getting things done. But they might need your help with measuring results. And we know that many of you here are excellent at measuring results, and sometimes even engaging citizens in measuring results, but maybe not at doing all the 3 things at once. And so that's where we need to find ourselves, in that sweet spot where we all have something to contribute and something to offer. So community improves quality. And what you can do is prioritize community governance, including data sovereignty. You heard earlier about the OCAP and EGAP principles. You can recognize community knowledge production, interpretation, and learning. And you can support community self-determination for sustainable health promotion and upstream action. I'm going to talk a little bit more about that one next. Because I want to say here, should be number 4, community brings the joy. There is something beautiful about just working together and being together. And that's the work of health promotion, enabling people to increase control over and to improve their own health and well-being and the conditions for their own health and well-being. That's health promotion. That's moving us toward that more upstream approach. And self-determination has 4 critical components that are really important and that will help you to bring the joy into the work. One of them is remembering that communities and individuals have autonomy. They need to have the knowledge that they can make decisions for themselves about their own care, about their own data, about their own health interventions. Communities have competence. There's a lot of skill and a lot of capacity, and sometimes we need to be reminded of that within communities and also in working with communities. It's core to self-determination that people know and are respected for the competence that they bring to the table. Relatedness. We all had that experience of social isolation and disconnection, and also feeling, many of us, in particularly in racialized communities, people experiencing disability, and LGBTQ2S plus populations, feeling not prioritized during COVID by some of the policy decisions that were taken. We want to make sure that we're improving that sense of belonging for community organizations, for community members, and for individual people. It's critical to our ability to self-determine. And the last one, beneficence. And that really just means our ability to give back. When we volunteer or we offer a smile of welcoming, when we break bread together, we are reminding ourselves and others that it feels really good to give and that we all have something to offer. And we need to tap into that and remember that when we're working together in community. That's the work of co-production with individuals and communities, delivering the outcomes that actually matter to people, better efficiency in the long run, that work and that commitment to a more socially just health and care system, empowered people and stronger capacity, and then that human connection whereby we are working towards some shared goals. That's the value of doing that work together. So community brings the joy. And here's what you can do to enact that in the work that you do and in your lives. Support that self-determination. Remember that you are a citizen, a small c citizen. I'm not just talking about people who hold a particular capital C citizenship, but you're an active member of civic life. You're part of community. You're not just a professional. And we need to challenge norms of professionalism that help us, that make us forget that. that we should bring who we are to the work we do and make it safer and easier for other people to do that too. Make that space for your fuller self. Take the time to eat together. Take the time to build relationships and get to know people. Find that sense of purpose in your work again. And, many of us have been burnt out by the COVID-19 experience and other healthcare work in a time of acute crisis. And that self-determination and joyful abundance mindset can make a big difference in our ability to sustain this work. So here are the principles as a little bit of a wrap up. Community supports our health. It's part of our health. We can no longer make it invisible. It has a health history that comes from somewhere, and we need to really be in touch with where it comes from and how we might use that in understanding how to change it. It improves quality, and we just won't have good quality work without it, and it can really bring the joy. So I'm just going to end by translating those into 4 actions that you can take for building a community that moves us forward together, that really puts our work on equity data into action. Make those community contributions visible when you engage with health systems. Take those community health histories and really try to understand the antecedents of inequity that you see in your work and in your life. Build in that community governance so that we all have better outcomes. And don't forget to bring the joy. Support self-determination and health for your being and for everyone's. Thanks so much, and I hope we'll have time for 1 or 2 questions.
Kate, that was a tour de force. That was really fantastic. Thank you so much for sharing that perspective, which definitely built on the previous panel, but also added a whole lot of insight and expertise. So we really only have a couple of minutes. So I'm just going to ask one question, and it kind of gets at the issue of what is community. And I think it's interesting, the way you framed it, that for a lot of us who are really immersed in the professional world and maybe in kind of the privileged cultures and privileged communities, we don't really think in terms of community anymore, or at least not as much as we used to. And so one question from me is, when you think about community services, that's mental health or a whole range of health services, can they actually be formally affiliated or attached in some way to some of the more traditional structures, like a hospital or a primary care practice or a community health center? Or do they need to be, are they better delivered if they truly are a product of a community organization that is completely distinct, even if there's collaboration and so on?
Well, I am a proponent of social prescribing, so I really think there are some important benefits of making those connections. And it doesn't mean we need to over-medicalize all of our social lives. There are many important things that happen outside of healthcare systems. But one of the things we need to do is to start measuring and telling back to the healthcare system, what is the impact of all this work on our health systems, on our health experiences, and on our health outcomes? And we kind of know that in a generic way, but can we do it in a very specific way by tracking individual and community level outcomes and really link to what is the work that those community organizations, formal and informal, offer? So I really do think there's a lot of promise in approaches that make those links, even if we do preserve some autonomy for the parts where we need more autonomy.
All right, well, that is absolutely terrific. There actually are a whole lot of questions here, so maybe I'm going to try to sneak one in. We've got like 2 minutes, I think.
Let's do it.
Just to make the point that for us, for ICS, I think the point about making community visible and making those services visible through data and partnerships, I think is a critical challenge. So here's a question that I'm just kind of picking at random here, but Tommy Tam is asking, from your perspective, what's your suggestion on one thing that we as individuals can do today to build the community? Also, what is one thing that organizations can do today?
Oh, that's a great question. So first of all, you can go check out Vivek Murthy's report. He's the U.S. Surgeon General. He just put out a big report last week all about social connectedness and how vital it is to our resilience and survival, really, as individual people and as communities. So to build community, tap back into the things that give you a sense of purpose. I know, for myself, I've got young kids, so I have a bit of community around engaging with them. And it's like having a pet. We go around in the neighborhood, people find us, we get to know people. So tap back into something that creates well-being in your own life and find other people who are doing that with you. And if you already have that going on in your organization, bring a little bit more of that hat to work again. I think we've been over professionalized in our work and taught to create a firewall between our work selves and the rest of our lives. And that is causing problems for health equity and community building. And it's our job to rectify that.
All right. Well, Kate, I think we're going to have to call it an end to the session there. We have tons more questions. You've generated huge amounts of interest, which is terrific to see. So thank you again for a terrific presentation, terrific keynote. And now for everyone, we'll move into the next panel, the third panel. So if you exit this session and come back immediately to panel number 3, we'll get started over there. Bye for now.
Thank you.